Uh, our next speaker is Professor Mark Lawler, who is an Associate Director of Health Data Research, Wales and Northern Ireland, and also Scientific Director of DataCan, the UK's National Health Data Research Hub for Cancer. He also has a strong commitment to patient-centered research and care and was architect of the European Cancer Patients' Bill of Rights, launched in the European Parliament on World Cancer Day 2014. The topic is "Don't let cancer become the forgotten sea in the fight against COVID-19." So I hand over to Professor Lawler, and thank you very much for joining us.
Thank you very much, Borislav. You can see my slides okay?
Perfect, thank you.
Thank you, okay. So thank you very much, and thank you very much to the organizers of Biotech Atelier for inviting me to give this talk. For me, COVID-19 was actually a very personal experience. Unfortunately, my uncle passed away from a COVID-related illness on the 29th of March, 2020. One of my colleagues, Edward Vodoliak, who's a Croatian oncologist, while he was reaching out to me to sympathize with me on my loss, he said something that really made me think. He said that in Croatia, people are starting to fear a COVID-19 diagnosis more than a cancer diagnosis. And I thought about that a lot and also discussed it with my colleague Richard Sullivan. And we said to ourselves, yes, we've heard anecdotally that that's the case, but there was really no evidence or no data to actually either support or refute that statement that Edward had made. So we decided that we wanted to go away and actually find the data and look to see what was the case. So this is a collaboration between DataCan, I'm scientific director of DataCan, and University College London. And what we did was two things initially. We looked at accessing real-time data from hospitals across the United Kingdom, and then as a second part of the study to model excess deaths if there were any due to the adverse impact of COVID-19. And what we found was really worrying. First, if we look at the diagnostic pathways, so in the United Kingdom, we have what's called the 2-week wait time, sometimes called urgent referrals. And it's really an early warning system for individuals who may have suspicious symptoms of cancer. And what we found was that 7 out of 10, yeah, that's not a misprint, 7 out of 10 people with a suspicion of cancer were not getting referred at the appropriate time to specialist services, either because they were too scared to actually go to the clinic or the clinic wasn't open because of COVID and the restrictions to do with the lockdowns. Secondly, we also looked at the cancer treatment pathway and we looked at chemotherapy attendances, and again, a significant impact. 4 out of 10 cancer patients not getting access to their chemotherapy at the scheduled time. And this really was the first data in the UK that drew attention to governments, to academia, to the NHS and to the public, to the disastrous impact of COVID, both on cancer services, but more importantly on cancer patients. One of the things you might ask me is, why do we need real-time data? So we collected weekly data from hospital trusts across the United Kingdom. And I hope this slide shows you why we needed real-time data. So this was national data that was available at the time. And when you look at it, you don't really see any difference. So this was taken at a particular moment of time, the 9th of June, 2020. And what we see, it's a relatively straight line across. The reason for that is, although this data, we looked at this for this date on the 9th of June, it was actually only from March 2020. So there's only data available up to March 2020. So if you like, it was out of date. And obviously it didn't show any impact of the COVID pandemic because it was only in the March-April period that we started to see that. If you contrast that with our data, the real-time data, you can see there much more detailed. It shows the drop, the precipitous drop that we saw around the time of the pandemic lockdown, and also the start of the recovery. And that's because that data is actually only 4 days old. So it's from the 5th of June. So just looking at the same time point at our data and at national data, you can see the difference and why we need real-time data. Unfortunately, the impact that we saw in both cancer diagnosis and cancer treatment was actually seen right across the pathway. So in terms of presentation, so for example, many screening approaches were stopped in terms of diagnosis and in terms of treatment. We also saw significant impact on cancer research, both in relation to clinical trials and in relation to lab-based research. We then looked to see, could we actually model the potential impact of the lockdowns on what we had seen in relation to excess deaths in people with cancer. And we looked at a data set from nearly 4 million citizens from across the United Kingdom. It's a linked primary second care data set. And we looked at different scenarios that we modeled using the real-time data that I've just showed you to inform our model. And what we found was that between 7,000 and 18,000 excess deaths were potentially going to happen due to the impact of COVID. And you have to remember that every one of those is a person. And it's really important that we remember that and not get swallowed up by the statistics all the time. We also looked to see were there any other underlying health comorbidities that may also influence the risk of dying early due to cancer, due to COVID impact. And we found that, for example, the presence of cardiovascular disease, hypertension, obesity, diabetes, and COPD were additional risk factors. So really, what we're seeing is, if we look in the UK and indeed across Europe, our actual 5-year survivals have improved over the last 10 to 15 years. We've seen great improvements, as you can see here. These plots here for lung, breast, and colorectal are from 2005 to 2018, 2019. But what we can see is that if we look to see what's the potential impact due to the disruption in relation to the lockdowns, stage shift because we're not diagnosing cancer at the earliest possible stage, what we can see is for lung, we're actually setting back a number of years in relation to our progress. For breast, we're going right back so that we're only at the level that we were at between 2011 and 2012. For colorectal, we're more than a decade behind in relation to the impact on 5-year anticipated survival. And so really, this is very serious and we really need to act to address this issue. We shared this results pre-submitting to a medical journal with the 4 chief medical officers from the 4 nations of the United Kingdom and also the National Cancer Director. And this contributed to the decision to start to restore cancer services. You can see there's a whole load of different impacts we've had in relation to in the research community, pharmaceutical community, but also the public in relation to the impact that COVID-19 has had both on cancer patients and on cancer services. But also data, as well as highlighting what the problem is also helping us to support the recovery. And a good example of that is in colorectal cancer, where we've actually used the data in terms of prioritizing, for example, the use of fecal immunochemical testing to avoid a lot of the excess deaths that I talked to you about earlier. Because we can actually look at ways in which we can triage using this approach so that we don't require colonoscopy, which obviously was greatly curtailed during the pandemic. So you can see here you're using data both to support the health system in terms of solving potential capacity problems, but most importantly also identifying which patients need to be given colonoscopies and which patients don't. So that prioritization really can then reduce the diagnostic or presentational delay. However, even though we saw recoveries, those recoveries were actually quite varied. And you can see in this slide here, just showing you the difference in relation to something like breast, which got back to nearly 100%, whereas something like lung cancer only at 67% recovery. Similarly, if we look at this, and this is data from my colleague Jeff Hall, who's the clinical lead in DataCam, and this is particular data from Leeds. Again, we have these 1,400 missing diagnoses. We estimate in the UK in general 85,000 missing diagnoses. We also then looked at the impact, for example, on endoscopies, a very common procedure that we use to diagnose a number of different cancers of the gastrointestinal tract. This data really worried me. Look at what we can see there. The difference between 2020 and 2019, nearly a 90% difference. So really that drop means that we probably have missed or delayed up to 500,000 endoscopy procedures. As you can see, again, the recovery has not been complete. We presented our data to the European Cancer Organization and also to WHO Europe. And in light of this data and also other data that was accumulating from across Europe, the board of the European Cancer Organization decided to set up a special network on the impact of COVID-19 and cancer. And I'm proud, along with my colleague Miriam Krul, to co-chair this committee. We've brought together a wide range of stakeholders from our member societies in the European Cancer Organization, from our very strong patient advocacy committee, which represents 26 different organizations right across Europe, and from Community 365, which represents both foundations and industry. And really to look at delineating what are the challenges that COVID-19 is presenting, can we amplify activities in order to address these challenges, and can we come up with recommendations? And we work together to develop a 7-point plan really to mitigate the impact of COVID-19 on both cancer service and cancer patients. Here you see the 7 points of the plan. Most important, addressing that cancer backlog that I mentioned, but also restoring confidence, both of citizens and patients in our health services. Tackle shortages, look at cancer workforce gaps, strengthen cancer systems. We really have an opportunity here to reimagine cancer systems and cancer services to make them better than they were before. And crucial to this is this rapid deployment of cancer intelligence that I talked about and showed you examples of earlier. So cancer cannot become the forgotten sea in the fight against COVID-19. Following somewhat on the launch of our 7-point plan, we're approached by a number of different stakeholders to ask, would we consider running a campaign on the impact of COVID and cancer? And we've done that. The campaign is called the Time to Act campaign. It's in 2 parts. The first part is a data intelligence study, really to identify what's happening at a European level, but also then using that to inform a campaign. We presented our data initially to the European Beating Cancer Committee on the 10th of May, 2021, and really some of this data, again, is very worrying. If you look here, just 2 examples from this page. Cancer screening, 100 million. Yes, that's not a mistake, that number is correct. 100 million cancer screening tests were not performed in Europe as a result of the pandemic. And also, we may have up to 1 million people walking around with an undiagnosed cancer. Similarly, if we look at the impact on treatment, particularly in chemotherapy and surgery, you can see the significant impact in terms of 1 of 2 patients not receiving the surgery or the chemotherapy they required at the appropriate time. And also, patients and citizens afraid to attend their hospital for screening appointments, and also patients afraid to go to their hospital for cancer treatment in case they get COVID. And also there's been the impact on the workforce. 4 out of 10 feeling burnout, 3 out of 10 with clinical signs of depression. So very worrying figures. So these really have informed our campaign. As I said, it's called Time to Act. Cancer won't wait, so neither can we. We've translated it into 30 European languages, and it's aimed at 3 different audiences. So most importantly, cancer patients and citizens. So if you have warning signs of cancer, so if you have a lump on your breast, if you're bleeding from your PRP, if you have difficulty swallowing, if you have unexplained weight loss, please go and see your doctor. And also keep any screening or treatment appointments you have. And also to emphasize that cancer services are safe. For healthcare professionals, working together is the way in which we get through this. Really look at what are the best standards that we can actually deliver, optimizing best practices between different healthcare professionals. And then policymakers and health services leaders, or health system leaders, we really need to put cancer back on top of the agenda. Everything we do now will actually help to save lives. This patient-centered initiative very much has pan-European relevance. So as well as having the virtual launch on the 11th of May in the European Parliament by Stella Kyriakides, we've also had national launches to date in Poland, in Italy, and in Spain, in Romania, and in Malta, and also in France, and with other launches coming up in the next number of weeks, and also a number of other countries under negotiation. The work that we did won an award in Spain, again emphasizing its relevance and its importance to the citizen, to the patient, because that's really what this is aimed for, is to provide the best possible support that we can to our citizens and to our patients. And the Time to Act is for everybody. You can play your part. Please engage with us in the campaign. I've given you both the website and the hashtag there, and look at ways in which you can support national launches, share the campaign materials that we've translated and the videos in over 30 different European languages. As I said, every action we take will help save lives. And this work, emphasizing its relevance, recently received the 2021 Royal College of Physicians Excellence in Patient Care Award. And I think it emphasizes, don't let COVID-19 stop you from tackling cancer. And again, it emphasizes really the power of data to enhance and improve cancer care and control, both for the citizen and for the patient. Thank you very much for your attention.
Thank you very much for the presentation. It was both scientific and emotional. And if you don't mind, I can give another piece, the picture. Not only we step back from where we were in cancer treatment, but after the outbreak of COVID last year, 90% from the clinical trials were cancelled or put on hold or stopped or logistically damaged or off-IP. I can give you a long line because I come from clinical trial, I can say battlefield, and it was devastating. So, which can be probably translated in that we delayed the scientific progress for probably thousands of patients. And now everybody talks about healthcare being challenged or damaged, but the research was very, very badly impacted because I have never seen in my over 20 years of experience, I've never seen such a devastating situation with the clinical research. Still, industry is coming back, trials are restarting, but we still face a lot of issues and a lot of troubles with what happened. So would you like to elaborate a bit more?
Absolutely, Borislav, and we saw very similar data, varied in different countries. Some countries were able to actually perform better in relation to cancer clinical trials, which certainly had a significant impact in Northern Ireland, for example, in my own country. Again, it was probably similar levels, 80 to 90%. I think it was 80%, but significant challenges. And one of the things, people forget, clinical trials and cancer research is not an add-on. It's an integral part of what we're delivering now as modern medicine. We've done a study, and a number of other people have done studies in particular diseases. We've done a sort of an overall study, a meta-analysis, if you like, to show that patients who are treated in research-active hospitals have better outcomes than those who are not. So it's now undeniable that cancer research contributes to better outcomes for patients. And so the impact, both in terms of clinical trials, but also a lot of laboratories obviously had to shut down for periods of time, experiments had to be stopped, etc. And also funding has been significantly impacted, particularly from, for example, the cancer charities like Cancer Research UK, which is a huge funder of cancer research, had to cut a significant, something like 100 million off its budget. So it's really had a significant impact on cancer research. And I think you're right. Obviously, we focus on, and it's quite right to focus on the impact on presentation, diagnosis, and treatment. But let's not forget the impact it's also had on cancer research.
Thank you very much. Any questions from the audience?
Not yet.
I'd like also to thank you about bringing real world data, because it's been a hot topic always, but that's a slightly different approach in real world data. So
yeah, no, and it's one of the things we're now pressing for. We were asked by pathologists and cancer specialists in Ireland to do a similar study with them to look to see what the impact was. And one of the things we're recommending is that they really need to have much more real-time data. Because to be honest, if we're getting data that's 3 or 6 or 9 months out of date, it's really like trying to fight cancer with one hand tied behind your back, to be perfectly frank, and not to put too fine a point on it. So it's really important that we are able to access that data in near real time, because that's the only way. So we were the first to show in the UK this has happened. If we'd relied on national data, we wouldn't have seen anything. So that's why we went to the different hospital trusts to actually collect that, as you say, real-time data. And I think more and more we're realising the importance of real-time data as part of our armamentarium against cancer.
Congratulations, really amazing job. And
Thank you very much.